I'm really delighted to be able to welcome our guest today, Dr. Uli Chettipally, who is both an MD and an MPH. Dr. Chettipally is a pioneer at the intersection of two things that we all find very interesting here at Google, which is artificial intelligence and healthcare. He's the co-founder and CTO of Kaiser Permanente's CREST network, where he's received the Pioneer Award from Kaiser Permanente Innovations for his groundbreaking use of clinical decision support technologies. He's presented at many scientific meetings and industry events, such as Big Data 360, Medical MEMS, I'm going to say these all wrong, and Sensors, Connected Healthcare, Maxim Integrated Health Technology Forum, and others. And he's an assistant clinical professor of medicine at UCSF, as well as a clinical researcher at the Kaiser Foundation Research Institute, and has published articles in a variety of peer-reviewed journals. He received his medical training from the Charles R. Drew University of Medicine and Science in Los Angeles, and has his master's in public health from UCLA. Also, we hope that you will keep an eye out for his forthcoming book, which is coming out this year, which we're hoping that he will tell you more about during this presentation. So, round of applause for Dr. Chettipally, and look forward to having you up.
Thank you. Thank you, Mr. Al. And thanks for everybody who came in remotely and otherwise in this room. It's a pleasure to be here. I always wanted to come here and talk about a little bit about healthcare. Because the technology piece you guys already know. So I'm not going to touch too much about the technology side, more about how healthcare has changed and how technology can help get better at saving patients' lives and also hopefully protecting physicians from burnout and all the difficult situations they're in right now. As described by Mr. Al, my name is Uli Chettipally. I'm a physician and a researcher and a scientist at Kaiser Permanente. I see patients in the emergency department. That's my main profession. But I also do research. One of the key things that I found was that, when you're seeing patients, you can make a difference in one patient at a time. When you work in research and technology, you can make a difference in hundreds and thousands and probably millions of patients. And so that's what gets me really excited about working in research and technology. My group, CREST Network, is a group of 12 or now 13 physician scientists. All of us are trained in emergency medicine, and all of us are researchers. So we see patients, and also we do research on the things that interest us. We have a staff, about 4 or 5 people, right here at Division of Research in Oakland, and we tackle some of the big ticket items like stroke, heart attacks, and sepsis and things like that. So I'm one of the co-founders of that group, and also I help design the technology for that. Let's see, I teach medical students and residents at UCSF. They come to us for their medical rotations in the emergency department. And I also run a group called Society of Physician Entrepreneurs. It's a large a group of entrepreneurs, healthcare entrepreneurs who are interested in changing healthcare. I run the San Francisco Bay Area chapter, and we meet every third Thursday, and so all of you are welcome. It's open to everybody. You can check out the invitation on LinkedIn. Let's see. Disclosures. I have nothing to disclose right now. I'm employed by Kaiser Permanente, and I do research. But the views that I'm expressing here are totally mine, and it doesn't. I don't get any industry money or anything like that. When I was thinking about doing this talk, I know you guys know technology very well, but I thought I would give you a little brief introduction to healthcare in the United States and how it has changed over time, and what are the challenges now, and how to deal with some of those challenges. So I'm going to divide my talk into three areas, three eras. The golden era, where about 100 years ago or so, when medical science started revealing to us the secrets of disease and how disease happens and how to prevent it. And I call the second era the steel era. Steel era is where you're looking at industrialization of countries and huge growth of large companies, large industries, large hospital systems, diagnostic abilities and surgeries. So everything that has to do with building large things, and that's the steel era that we talk about today. And then comes the digital era. That's more recent times. How digitization of medicine has changed and will change in the future. So that's talking more about the future and how technology can help. The golden era, this is probably 1850s or so. It starts around that time where the germ theory came about, where scientists figured out that germs are the ones that cause disease, and how to treat them, how to kill them with antibiotics, and a lot of causes of diseases were found in that, I would say, about 100 years time frame. And I have a lot of my heroes, being an epidemiologist by training, a lot of my heroes are from this era. So I'll talk about a few of those. First one that comes to my mind is John Snow. He was a physician in England. And during the 1950s, there was a bad cholera epidemic in England. And so he was the one who started investigating this. He was one of the earliest scientists, or data scientists, I could say, in healthcare. So what he did was he took a map and started putting dots on where people were dying of cholera. And so this is a map, this is the original map that he worked on. And you can see those black dots along the streets, and those are the places where people died. And then what he did was he looked at one area which was a very dense area where there were a lot of deaths happening. And that's on Broad Street. And then he figured out that there was a pump, a water pump, called the Broad Street pump, which he felt that somehow that water coming from that pump was the one that is causing this disease. And so he put out this theory first. Until that time, people were thinking that the air is what causes cholera. And so eventually what he did was he removed the handle on the pump. These pumps had handles where you have to pump to get water. He removed the handle on that pump, and lo and behold, cholera was declining. And then later on, they found out that it was the source of water that was contaminated, and that was causing cholera. And that pump still is up there in England, in London. The second one, I'm sure you know this person, Florence Nightingale. She was a duchess. Actually, they call her Duchy. She was a daughter of a rich person in England. Again, she was good at mathematics, another data scientist, and she went and worked with the wounded veterans during the war, and this was in the 1950s also. And what she did was she did enumerate the causes of death in these soldiers. And you have this, and she prepared this beautiful graphs, or this is one of the first, I guess, infographics where she described. So each of those slices is a month's time, and the gray area or the blue area, as she describes it, as preventable deaths. The black area is where other causes or unknown causes. And the pink areas, or the red areas in her description, are the deaths from the wounds, from bleeding. And so and remember, this was even before there was antibiotics, or there was, the germ theory wasn't even published yet. So she, just by observation, she was able to figure out a lot of things using data science. Luther Terry was a physician in the United States in the JFK era. He was the Surgeon General of the United States. He had a tough choice of putting out a warning that you see on the cigarette labels. And this was the first time that people realized that cigarette smoking was injurious to health. And that was the warning that he's the one that is the person behind this committee that sat together, looked at all the evidence coming from the public health data. And soon they realized that, wow, we are all smoking, and probably 75% of those physicians, including Terry, was a smoker. And imagine how hard it must have been trying to look at that evidence, and which shows that smoking is causing cancer and other diseases. And so he was one of my heroes. Thomas Dauber was another physician who was the lead investigator in the Framingham study. Framingham is a town in Massachusetts. And so in the 50s, what they did was they picked this town and enrolled all the people in the town, all the adults in the town, about 5,000 of them, and then tracked their health histories, tracked their diet, tracked their activity, tracked their blood tests, blood pressures, and everything. And there were about 1,000 papers that came out of that study, and they studied for years and years and years, and they're still studying that population, which is now in the third generation. And so this is where we got a lot of the good data about what causes heart disease, and these are the risk factors that they found, which we still practice today. So those were all the great things that happened in those days that changed the lives of millions of people, that actually saved a lot of people too. Coming to the steel era, this is the industrialized nations, starting anywhere from the 50s, 60s to 2000s, early 2000s. So this is where everything is growing, big hospitals, big hospital systems. Electronic health records were introduced, and they were doing all kinds of surgeries, saving lives and very complicated procedures. And everything blossomed, and healthcare became this huge industry. It is all great, except that it was getting out of hand. And so I'll show you some of the things. I think, based on my 25 years of experience, 50% of what we do in the clinics in the US is a total waste of money and effort. It's unnecessary, ineffective, or dangerous. Now you must be thinking, looking at that data, I don't believe it. I don't think that's true. I don't think this guy has 25 years of experience. But it's true. I do have 25 years of experience, and I think it is 50% of it is unnecessary. So you must be, when you go to your doctor, I'm sure you must be thinking, wow, what part of this 50%, what part of this care is not necessary or dangerous. So I'll go over a few things to show you what is happening in the industry right now. This is from Harvard Business Review. The population is aging, right? So one of the problems with aging population is that the cost of care goes up. You know, if you're a 30-year-old, maybe it'll cost about $5,000 a year to take care of you. But if you're a 65-year-old, it'll cost $20,000. And so if everybody is getting older, that means the cost of care will get higher and higher. This other graph I love because it shows the largest economies in the world. You know, the tall, big blue one is the United States, and as you guessed right, the second orange one is China, and then comes Japan in the gray one, and the yellow one is Germany, and then, of course, UK and France and other countries follow. Now, healthcare, if you look at it, it'll fit right there, the US healthcare. That's the red one in the middle. We spend that much money on healthcare every year. We spend almost as much as the whole economy of Germany. And you know how big that is. That is the fourth biggest country in the world as far as GDP is concerned. And so that is what I'm talking about when I talk about the cost of healthcare. This is a consumer price index of various things that we buy. The ones in the bottom are clothing, food, and other transportation, things like that. The purple one at the top is healthcare. Healthcare costs keep going up and up and up. This is another graph talks about quality and spending, and healthcare is right there. All the other industrialized countries, developed countries, are up, spend less and have a better performance or better quality of care. We spend more and our quality of care is less. And the knowledge keeps growing. It's not like we don't know what the science behind the diseases. These are the number of studies that the clinical trials that happen in the U.S. and that keeps going up. And the 2017 number is only up till August. And so actually, 2018 is probably shooting up out of this screen. Physicians are facing a difficult time, mainly because most of the compensation comes from a fee-for-service world, and so they are worried about their reimbursement. That means they have to work harder, see more patients, do more things to make the same amount of money. And then, of course, there's a lot of pressure from the payers or the insurance companies. The regulations are getting more complex. That means they have to do more and more and check more boxes. And same thing with medical legal risk, where they are worried about getting sued, so they order more tests so that they are covered in case something goes wrong, and then that increases their workload and their effort and their stress. Which ultimately says that, this is a survey from Medscape, which shows that 51% of physicians, they complain about burnout. That's a sad thing if half of our physicians are not feeling good about their jobs, about their workload. On the technology side, as you know, data availability, there's a lot of data being collected, 1,000-fold increase. Hardware speeds are increasing, and algorithms are getting better and better. So now we come to the current age, which is the digital era. This is where I will talk about some of the solutions or how to tackle these problems that we have seen that have grown out of the industrial era or the steel era. Now we have, all 80% of the medical records are digitized, or EHRs are pretty prevalent. Hopefully the efficiency will get better and the quality will get better. And of course, artificial intelligence seems to be getting inroads into healthcare, and which looks like a promising era. Within my research, I do work with several groups here locally and nationally, but we know that this is where I think the biggest bang for the buck lies. Let me share a story with you, that kind of portrays current healthcare situation. There was a town which has a river flowing through a small town, and there's a bridge there. One day, one person was walking across the bridge and then saw a child floating in the water. Actually, the child was trying to swim and could not swim and kind of floating away in the river. And so he tries to put his hand and puts his, throws a rope and then saves the child, brings him out. And then soon after, another child is coming along the river. And then he saves that child too. And then more and more people are coming, trying to survive this flood of water that is going under the bridge. And soon enough, he calls his friends, and everybody is trying to save these people out of the water. Soon they set up some tents, some fire, some food, and everything, and they realize that there's more people coming. And so they set up a nice building, hotels, and they build all this infrastructure around that bridge because they see people floating. And some of them are dying. And so one wise person comes by and says, hey, do you guys know where these people are coming from? Maybe we should go there and stop that. That thought of preventing disease and illness and death is what I'm talking about when I talk about, how technology can help. If you look at healthcare industry in general, it's very complex. You have the physicians on one side and the patients, which are the two most important pieces in healthcare. But then you have the pharma, the medical devices, the academia, regulators, small practice, and payers, right? But each of those groups have something else in their minds. The pharma, they are looking at getting their FDA approval, they're looking at selling these drugs and eventually making profits, which is a good thing. The same thing with devices. And in academia, you see doctors, trying to publish papers, because if you don't publish, you don't survive. But one of the big things that you realize is that, is their primary goal to help patients? Same thing with regulators. They're trying to, control the quality, and malpractice, same thing. The lawyers are trying to control the malpractice so that, we can weed out the bad doctors. Insurance companies trying to hold down costs. But then in the mix, the physicians and patients are getting lost. They are not the main focus of all these other institutions that have grown around this healthcare. All physicians want is to be able to take care of patients and then hopefully decrease all these other burdens that come in the way. So one of the best ways is, now I'm talking about solutions and how to steer this wave of increased costs and decreased quality. Number one, I think the business model has to change, and it's already changing in healthcare, from volume-based care to value-based care. So when you talk about volume-based care is, the more procedures you do, the more money you make, the more operations, the more drugs, the more hospitalizations. I think it has to be flipped, where when you keep the patients healthy, that's when you make money. And that switch is already happening, and that has to happen. The second thing is that we have to go upstream. When I say upstream, we don't want to spend too much effort on people who are really, really sick, but try to see how we can prevent this sickness even before it happens. So you have to look at not just the hospital, but you have to look at the environment, the home, the city where they live in, the zip code. They say zip code is more important than your genetic code. And then you go upstream, are there any genetic factors? We look at those things later. But the idea is to go upstream so that you can attack the problem early on before it becomes a major problem. Because the more to the right you go, the more expensive it becomes to deal with the problems. The scientific method has changed, or let me put it this way. The scientific method is there. You typically ask a question, you collect a sample of data, and then you get an answer. But then with AI, you do have the data. You don't have to collect a sample, although you could. The key is to ask the right questions and be able to get the answers. One thing I keep saying is that healthcare is an information business. And the sooner we realize it, the more lives we can save. Because the way you deal with the information, the way you can analyze the information, the way you can extract knowledge out of it becomes key when you want to save patients. I like this paper that came out a long time ago. Chris Anderson wrote this, The End of Theory. The data deluge makes the scientific method obsolete. In a way, we are seeing that right now because one of the problems with scientific method is that you take a sample from a big population, you collect that study sample, and then you study it, and then you learn things and apply that knowledge to your target population. Right now, you have the whole target population. You go through these steps, collecting data, analyzing and translating, implementing science. But then it takes a long time. It takes about 18 years on average from an idea to studying it, to analyzing it, implementing it, and then actually the patient coming to the bedside where the patients are actually using that. I want this to speed up. It should take less than a second to be able to get that data. In this day and age, we should have access to all that data. We should have analytics and engines that can work harder. And this is what I mean by punish the machine, is that the idea that we have this technology and we just letting it sit there and not being used for the good of mankind. A lot of value-based systems, as you might have noticed or understood from, initially there used to be a lot of procedures. I don't know if you remember, but we used to do a lot of tonsillectomies and hysterectomies and all kinds of procedures. But we soon realized that, we could treat that with medication. Maybe soon we'll realize that a lot of the sickness and illnesses can be treated with diet. And now we're talking about more of the social determinants of health, how the social situations will contribute to illness and how we can prevent that. And so we have to go up that value chain. I want to talk a little bit about what I do. So my main key important people are the physicians and the patients, and that's all I care about. And how can we design systems that'll help the physicians take better care of the patients? We study data, and we go back and look at the retrospective data, because right now we have more than 10, 15 years worth of electronic health record data, and see what happens to these disease processes. How do people get sick? And then you study how you can predict it, what will happen. If you know that this person has these risk factors and soon they'll end up here, well, hopefully you can do something to change those risk factors and prescribe something that'll change the trajectory of that disease process. And so that's the idea. So we have descriptive analytics, predictive analytics, and prescriptive analytics. So what we have done is we've taken data and put it through our engines. By the way, this is a whole platform that is now active in Kaiser Permanente in Northern California, which is 21 hospitals and 21 emergency departments. And this is what we did. We created a platform that can then have the engine, have the modules for each disease process, and then have the clinical decision support system, which means that it'll tell the physician what the next step should be. For example, if a patient comes into the emergency with chest pain, we get a lot of patients in the emergency departments. In our 21 emergency departments, we have more than 1 million patients that go through our departments every year. Chest pain is probably number 2 or number 3 chief complaint, we call it. So people with chest pain, maybe 100,000 people come through these departments with chest pain. Only a few, maybe 5, 10, 15, 20% have serious disease, right? The other 80% do not have disease. But right now there are no systems. I mean, we do look at our Framingham study, but then that's a little bit old, because if we can figure out what their risks are, and so predicting the risk and then mitigating those risks, giving that information to the physician so that they can implement those strategies. So when a patient comes into the chest with chest pain, when the physician clicks a button in our medical record, it goes to our website. It opens up in the browser within the health record, and it walks them through a few steps, and eventually giving the physician the answer. The answer says this person has a chance of 0.003% of having a heart attack in the next 60 days. And so you should do A, B, and C. Now what it does is number 1, you're assessing the risk exactly for this patient based on your knowledge of 100,000 patients before, right? So you can actually guide this physician in the patient's care so that the best outcome can be had with the least cost and least workup. And so we are very excited about this. And right now we are looking at implementing an AI-based engine and replacing what we have right now, so that it becomes even more faster and more accurate, hopefully. And we do clinical trials looking at these technologies. So half of the medical centers have the technology, the other half do not, and then we track these patients to see what changes have happened within these entities. And so we are very excited and very happy about this. And we got an award for this from our innovation folks. So all the answers are there. All the data is there. The technology is there. Everything is there. All we need to do is ask the right questions. And when we ask the right questions, we get those answers. Well, this is my hope and my dream, is that when we have an AI-enabled care, the bad outcomes will go down and the good outcomes will go up. In the past, it used to be very doctor-specific, where, well, there's this great doctor in Houston or Boston or wherever, people used to go there, right? Now it is more system-specific. In other words, well, this is a great system. Oh, Cleveland Clinic. Oh, Kaiser Permanente. They have great quality. Eventually, it becomes more patient-specific, where you can actually, using the data of all these patients in the past, you can really fine-tune the care of each individual patient. In the past, it used to be high touch and no tech, in the olden days. Now it's kind of low touch and low tech. The current EMRs are very, very, what's the word? Hard to use. In the future, it'll be more high touch again, but high tech will be in the background because the physicians won't be directly interacting or entering data because the data is already there. So what does the future hold? Well, there are some great opportunities in healthcare to be able to make a difference in people's lives. This story, I saw it on American Heart Association's website. They put this story out about Justin because they see this as the triumph of the healthcare system. Okay? Justin had 4 heart attacks. He had 5 bypass surgeries. And believe it or not, he had 35 stents placed in his heart blood vessels. That's unbelievable. It's great that Justin survived this and is doing okay, I hope, after all this. Wouldn't it be great if we caught this problem before the heart attacks, before the bypass surgeries, before the 35 stents he had to be on? I think there is definitely potential there to be able to change this. As you may know, we're not doing that many bypass surgeries nowadays because we know that we can do that, we can do it better with medications. Even stents, we're not putting that many because we know that, with medication, you can actually, the outcomes are equal or better. In fact, there were 800,000 stents placed last year in the United States that were totally useless, that were not needed. Autism is a big area also. I feel there's a lot of potential there. It's a neurodevelopmental disorder. By the way, I know a little bit about it because I have a daughter with autism. So I kind of studied that a little bit. Neurodevelopmental disorder that is, kids are born with it and they have it for the rest of their lives. It's a very expensive disorder because it costs more than a few $1 million to take care of one child or one adult. And the incidence keeps growing. 1 in 59 was the last one, I think, and it keeps growing, and that's what CDC says. And nobody knows why this is happening. We don't have any clue. I mean, genes are probably involved, but that's only a small percentage. We don't know if there's something in the environment, if there's something that we are eating, that we are wearing, that we are, inhaling. But this problem keeps growing. Right now, it's so big that it has overshadowed all the developmental disorders, all the others. So this is bigger than anything else, and this is one of the most expensive disorders for the healthcare system. Another problem, opioid crisis. Over the past, I think, 20 years, so many people died of opioid abuse and during this crisis. And we don't have a solution for this. Well, we know that when we start people on opioid medications, if they are on opioid medicine for more than 3 days, there's a 20% chance that they could get hooked on that medicine for the rest of their lives. Imagine that. And we all must have taken at some point, right, after surgery or whatever. And there was a recent study in JAMA, Andrew Chang and others. They looked at, really, opioids, are they really that great? No. The pain control was the same between opioids and non-opioids. If you give Tylenol and Motrin, that's the same, even if you have a broken ankle. And so why are we doing this? How did this crisis happen for so many years, for so many lives lost? It's like the whole city of Seattle gone, vanished because of this crisis. Because we don't know the outcomes of what we are doing. We don't know. We haven't studied it. Maybe we should. Maybe we should look at what are the chances of these people that we are starting them on opioids that are going to end up dying in the future. Is it really helping their pain, or is it just building addicts out of it? So that's a big, huge problem where data science, I think, can help. Okay, so to conclude my talk, I'll tell you a story. There were about 1,000 years ago, there was a town, and in that town, it's a nice, peaceful town, farmers living there, families, and there was a king, and he was a nice king. He took care of those people. One time what happened was there was a dragon that came to that town, and it started attacking the chicken coops, and eating their chicken, because it was a small baby dragon. And so it was coming and destroying and breaking things. And this is the kind of dragon that spits fire, so it'll set fire on those things, and so destroys the property around. And so the farmers, and they know that it lives in the swamp right outside the town. And so the farmers, they came together at the council meeting and said, we got to do something about this. And so one of the farmers said, hey, what if we give the dragon the chicken every day? We feed him, we take him to his place and put it there so that he doesn't come here and burn these things up. Yeah, that's a great idea. And so they start taking chicken every day and tying him up near the swamp, and the dragon comes out at night, eats, and then goes back into the swamp. Soon they ran out of chicken. Then they started putting sheep, goats. They ran out of those goats and cows and everything. So now they said, okay, well, we have our kids, let's give our children to the dragon. And so they started tying these kids. And so the dragon keeps eating, and the dragon is getting bigger and bigger. It wants more. And then all the children are gone. Now it's just the adults, except the king's daughter, the princess. She was a young teenager, and the farmer said, well, it's your turn, king. And the king was very sad because that was his only daughter. He had great hopes for her. But he gave his word that they will feed the children. So they tied her to a tree there. But then, before that happened, the king announced, if anybody can slay that dragon, I will give my daughter to you in a wedding, and you will have half of my kingdom. And so one shepherd boy came. He was another teenager. He said, well, I'll kill the dragon. Well, this guy was not a soldier. He didn't have any, weapons. All these guys had knives and swords, and they couldn't do anything. But he said, I will do it. And so what he did was he went there where the king's daughter was tied. He took the rope, and he hid behind a bush, waited for the dragon. And then he made a noose with the rope, threw it around its neck, tightened it, and so that the dragon cannot breathe fire or can't even breathe. And he dragged the dragon into the town and then eventually kills it. And that is St. George. For those of you, you must have seen some of these pictures. He became St. George, and he married, and everybody was happy after that. So the moral of the story is that we think about weapons, we think about things to attack a problem. This shepherd boy, he thought in a different way. He didn't think about, guns and knives and swords and spears. He thought about this rope. And we all have this rope with us. We just have to use it. So let's be smart and save some lives and save some doctors from grief. That's my talk for today, and I welcome any questions. Thank you for waiting here patiently. I invite you to join me in this fight. You can connect with me on LinkedIn. That's the easiest way. And I'm open to questions right now.
Thank you so much. So I do have a couple of questions on our online submission for those folks who are on the live stream, since the people on live stream are not able to speak directly into the room. So wanted to relay a couple of these. The first is, you said that 50% of what physicians do you see as potentially being unnecessary. The question is, do you believe that some part of this comes from living in an overly litigious culture where physicians become frightened of litigation, and that is why the unnecessary measures are being taken? Or do you see it coming as from some other source? They said, for example, bloated bureaucracies, et cetera.
So, as I showed you those three dragons, litigation is one of those. Documentation, saying that, okay, I did this because I need to get reimbursed. And the regulatory framework, which causes also to do more work. But there is a big gap in our knowledge. And so a lot of it is dogma, I feel. Oh, my professor taught me to do this way, and this is what the textbook says, so this is what I'm going to do. Not realizing that a lot of it may or may not be true, because there may not be scientific basis for whatever they're doing. I'll give you a good example. Ankle sprain, right? We've been taught, I don't know, for 50 years or so that it's the RICE protocol or RICE treatment, which is, now I'm trying to remember what RICE is. So rest, ice, C for compression, E for elevation. So you have to rest your ankle, you have to ice it, you have to put a bandage around it, compress it, and keep it elevated. I don't know, last time I sprained my ankle, I just walked, I just did nothing, and it got better. Really? So we don't know. Is rest better or walking is better? Is putting a compression better or, all those things. Is ice better or heat better? We have no idea because there's no data or research that supports what we are trying to do. So like that, there are several things that happen in healthcare that physicians don't know and nobody actually studied. So most of the research funding doesn't go to those kinds of simple things, right? There has to be a fancy drug or a fancy surgery or a device where, to get these researchers interested or the funding agencies interested so that, and so the cost keeps going up because you get these new drugs and so nobody's actually following up. Even when you have expensive drugs or expensive devices, we are not following them up to see, are they really working or is there something better? And so there's no way to know all these drugs on the market if they're really effective. I know they did a lot of research before they got approval, but once they get approval and once they are in the market and they're selling those, we don't know if that works or not. The research that happens is on a few thousand patients here, but then millions of patients are using those. But we are not tracking all the data on those millions of patients. So that's where the problem comes.
That is fascinating. We have a couple more that are coming in. popping up here. One is from Thomas Kwan in another part of Mountain View. And his question is, with Kaiser starting a new medical school next year, how do you plan to influence the curriculum to train physicians in AI or other digital era technologies?
I'm sure. So for those of you who don't know what the business model of Kaiser Permanente is, Kaiser Permanente is one of the value-based care models, one of the original value-based care models that was started 70 years ago. It so happens that now it has become the main thing because people are looking up to it. And value-based care model, in a value-based care model, the idea is to keep the patients healthy or prevent disease so that you get a fixed amount of money. And so if you keep the patients healthy, that means you make money when the patients are healthy. Which also means that we have to go upstream and look at their vaccinations, their colonoscopies, the mammograms, and all those things. How do we prevent cancer from happening there so that we can tackle it here? That in itself, now it is becoming more and more, the rest of the country is slowly trying to follow that model. Probably about 30-40% of the companies are healthcare companies are going to that model, and Medicare, the main government funding agency for healthcare delivery, is requiring more of these companies to do that. So yes, and what we found was that one of the big things is that in the traditional medical schools, they're all geared towards fee-for-service. That has been, the tradition, right? So that continues. That's one of the reasons why, Kaiser is planning to start their own medical school, and hopefully all this training will be part of that. How do you prevent? How do you go upstream and prevent problems later on? Right now, there is enough data that shows that, if you are a Kaiser Permanente. By the way, I'm not plugging in Kaiser Permanente, but this is just a scientific fact. If you're a Kaiser Permanente member, you have 50% less chance of having a stroke or 30% less chance of having a heart attack. Just FYI.
Just FYI. That's good for those of us who are near Kaiser facilities. Here, yes, we have one question from the audience. 1 second.
I have a question about kind of the decision tool that you're building, specifically around the fact that it takes a lot of information. So it both looks at unsuccessful cases as well as successful cases to help determine what the right path forward is. Looking very far out, if we continue to use that successful case and we continue to follow it, do we lose some of that training information that's important for that comparative assessment? And then kind of thinking beyond that and tying in with the Framingham study, like the longitudinal effects. So maybe we would have been told that opioids is really effective in treating pain medicine, but we wouldn't have necessarily seen what happens 5 years down the line, and kind of how some of the longitudinal effects are being incorporated into the decision tool.
That's a very good question. So this actually happened. So we were building this tool for a condition called pulmonary embolism. Pulmonary embolism is where you get a clot in your lung. It's like a lung attack, and you can't breathe, right? Some people die because it cuts off the circulation to the lungs and the brain. The brain doesn't get oxygen. So about 95% of these patients get admitted to the hospital as soon as they're diagnosed in the emergency. But we know that only a very small percentage of patients will have bad outcomes. And so how do you identify the ones that will have good outcomes and not keep those patients in the hospital, the low-risk ones, right? Because when you stay in the hospital, you are at risk for other things, hospital-acquired infections and stuff. Also, it's an inconvenience for the patient, and it's a cost for the hospital. So we did a study and said, okay, let's build this tool which can identify the low-risk patients. And we implemented it in 10 medical centers or 10 emergency departments, and the other 11 emergency departments were controls. And we followed these patients for more than a year, and we found that where this tool was available, it was very successful in decreasing the admission of unnecessary low-risk patients. What we also found was that, by the way, this tool, we pulled it from the literature. And this literature comes from Canada, Australia. And then what we found once we studied these patients was that this tool was actually overestimating the risk. Our patients are much healthier, are at much lower risk. And so version 2, what we did was we changed the dials on that so that it'll estimate the risk correctly. And so to answer your question, will we be losing data? Maybe. But maybe if we track everybody, we won't lose any data, even bad outcomes, good outcomes, you know. So, and then we have to constantly make the tool better and better. So each version becomes better as the population gets healthier. And so in the long run, it'll work great because, you know, the population gets better and the tool gets better at estimating the risk. But yeah, I understand that, you know, it does change our knowledge, and it does hopefully for the good.
If everyone has time to stick around for a couple more questions, I've got a few more that have popped up here. A quick one from Vivian Lee in Cambridge, Massachusetts. She says, thank you for the great description of the chest pain AI application in the Kaiser ERs. Do you have other examples you can share?
Sure. We did one study for head injury. You know, a lot of kids that come in with head injury, they fall and hit their heads. When they come in, you know, one of the tests we order is a CT scan of the head, right? And we know again from studies that CT scans, if you do a CT scan on kids, it's bad because it is radiation at a young age, and it predisposes that person to be at risk for cancer in the future. And so how do we decrease the CT scans? Especially in kids, you know, you have to, you know, the risk is higher. And so we designed the study where, you know, looking at the kids' features, how they present, can you identify the low-risk kids that don't need a CT scan? And we did the same thing for belly pain in kids. You know, what are the chances of this kid having appendicitis, which is the most, you know, dreaded diagnosis for these kids because, you know, you got to go through surgery. But then radiating them on their belly is probably the highest radiation a kid can get because it's a large area in a small child. And so right now that study is going on right now. And what we're trying to do is we're trying to decrease the number of radiations without, you know, missing appendicitis cases. That's a great one. And then, so like I said, you know, surgery is the treatment for appendicitis, but in the future, maybe it's antibiotics. Maybe it's changing in your diet. Maybe, you know, all those things we don't know because we never thought about it or studied it. So there's great information coming out of that.
Okay, final question, and then I think that we need to wrap up, although we do have a couple more here. There was one anonymized question that came in asking about single-payer systems like the European economies that you noted, which spend less but have higher quality of care. These systems are often accused of being overly costly for the country. Do you think that a single-payer model could work in a country like the United States? A nice, easy question for you.
That's beyond my scope. But, you know, I'm not a great business person. Economists may be able to answer that question better.
Well, Dr. Chettipally, thank you so much for being here. We're delighted to have you. And we very much look forward to both the book coming out and hearing more about what you're doing with AI and healthcare in the future. So thank you so much.
Yes, thank you.